Yeah, thank you very much. Good evening, everyone, and yeah, thanks for being here. As Manuel already said, my name is Leonie, and I'm working as the lead manager of the science department at mementor. Mementor is a software development company that specializes in digital sleep therapy, and my work very much focuses on providing clinical evidence for our developed products in clinical trials, but also in real world. And yeah, before I came to mementor, I was working as a sleep researcher at the University of Oxford, where I also met Manuel, and where I focused on the behavioral therapy for insomnia. And yeah, today I'll walk you through how emerging sleep technologies, especially digital CBTI, are being used in practice and what we can learn from the German DiGA model, which is a very special model of reimbursement, and also see a bit how technologies can change yeah, treatment situations in real world deployment. So a lot to cover today, and I will start with grounding this in the basics first. So what exactly do we mean by insomnia? Unfortunately, I don't know your background or what you've heard already, so I will just briefly give an overview and hope to not to bore you. At a high level, insomnia is not just bad sleep. It's defined as a sleep disorder characterized by difficulties initiating sleep, maintaining sleep, or waking too early with daytime consequences. So, meaning that those patients who experience insomnia often have problems with concentration, with their mood, with just having energy for their daytime core activities. And according to the ICD-10, insomnia involves unsatisfactory quantity or quality of sleep. That is, yeah, as I said, difficulty falling asleep, staying asleep, or early final awakening, occurring at least 3 times per week, which is quite a lot for more than 1 month. And crucially, yeah, with negative impact on daytime functioning. And depending on the diagnostic manual, the definition of chronicity can vary. So, for example, if we look into the DSM-5 or the upcoming ICD-11, insomnia needs to occur for more than 3 months in order to be classified as chronic insomnia. Otherwise, it would fall into the category of acute insomnia. So now you know briefly the criteria for insomnia. So how common is this? How long does it last? And why does it actually matter? Insomnia is highly prevalent. So about 1 in 10 adults meet diagnostic criteria in the European countries, and roughly 1 in 3 report subthreshold symptoms. The prevalence is higher in women than in men. And if we look into the global prevalence, so in the whole world, then we have an estimate of around 16% of adults affected. It is also very persistent, so about 75% still meet criteria 1 year later. 50% meet those criteria still at 3 years, and 45% experience it for more than 6 years. Unfortunately, it's also very disabling. I think most of you may relate to this. Yeah, if you haven't slept well for maybe just a day, but also maybe for a regular time, I think we very quickly noticed that without sleep, it's very hard to get through the day. It is very closely linked with mental health conditions, suicide risk, lower health-related quality of life, and reduced productivity. So it really is something that we should do something about. So given that burden and persistence, what do contemporary guidelines recommend that we do when we have insomnia? So briefly going into the European guideline for insomnia, this one was updated in 2023, and it continues to position CBTI, a specifically developed psychotherapy for treatment of insomnia, as first-line therapy, aligning with the broader evidence base. And on this slide, you can see the recommended treatment path of a patient with sleep problems. And yeah, we can briefly go through this path so you get an idea of what it should look like. So if we have a patient with sleep difficulties, and this patient would go to a healthcare professional, then the first step would be to figure out if there's a clinically significant impairment. So it's basically the question: are those diagnostic criteria that we've already been through, are they present or not? If they are, then the next question would be if the sleep pattern is in synchrony with the circadian rhythm. If it is, then we could go to the next step and just have a look if the intake of substance, if there's any intake of substances that affect sleep. If yes, then the first step would be to check those substances and see if this should be treated first. If it's a substance that is related to sleep, then it may also be that a CBTI for hypnotic dependence is the therapy that should be done. In most of the cases, there isn't any intake of substances. So in this case, then we would check, or the healthcare professional would check if there's any comorbid sleep disorder or any medical disorder. If yes, then the treatment would be to treat the comorbid disorder and insomnia. And if no, then we would go into the treatment path. So we would see here what I mentioned already: first-line treatment CBTI, either face-to-face or digital as first-line treatment option. And only if this treatment is not effective, we would go into medication. So either short-term medication, which could be hypnotics or sedating antidepressants or orexin antagonists for less than 4 weeks. And potentially also longer term treatment may be indicated. This is very much depending on the individual basis. And here, an option would also be an orexin antagonist or prescription-based melatonin for people over 55 years. So one important thing that I want to mention here already is the issue with the comorbid disorder. There's a very famous sentence from a sleep professional who always said, insomnia is insomnia is insomnia, which very much says that no matter how insomnia is present, it should always be treated. So the idea is that even if there is a comorbid disorder first, so for example, if we say we have a patient with depression and insomnia, the idea would always be to treat insomnia as well. And not leave insomnia outside and just treat the other disorder, because we typically know that if we don't treat insomnia, it will last and persist, how I showed you in the earlier slide. Yeah, so now this is basically the path that a patient should ideally have. But we actually have some evidence from insomnia researchers how this treatment path really looks like. And we can also quickly have a look into that, because I like this publication a lot. I think it's very interesting. So it was a publication in 2023 that aimed to map the insomnia patient journey in Europe and Canada based on surveys that were conducted with insomnia patients, but also with healthcare professionals. And now the question is, when does a patient actually consult a GP because of their sleep problem? And when are those patients receiving guideline recommended psychotherapy? The answer, and I think you can see this probably relatively quickly from this graph, is sadly almost never. So we can see very quickly that the ideal and the real path of insomnia care differs by quite a lot. But yeah, we can quickly go through this map of the insomnia journey in Europe. So we see first a patient who has those sleep difficulties. And most often the first thing that those patients do is that they initiate some behavior change. So maybe you can also relate to that. If you have a sleep problem, the first thing is maybe that you ask Google or you ask ChatGPT, what should I do about my sleep problem? And there may be some recommendations that might be quite helpful. So things like sleep hygiene, or reducing caffeine, reducing screen time, maybe engaging in relaxation techniques, and maybe also some people may change their diet or exercise. But we also quite often see unhealthy behavior. So we see that some people also use alcohol because they think it helps their sleep, because it makes you a bit sleepy in the evening. And also drug abuse may be something that is part of that self-initiated behavior change. As a next step, then we see OTC attempts, so over-the-counter remedies, maybe maybe seek things that you can get easily in a drugstore or pharmacy, but often they provide or fail to provide lasting relief. So then maybe a next step could be that the patient may consult their healthcare professional about some guidance. And sometimes here we also see that sleep hygiene guidance is recommended again, which at that point will be very frustrating to the patient because they have probably tried out most of these things themselves already. And then the next step that we most commonly see is that those patients then get recommended a sleep medication that is based on prescriptions. So yeah, the majority of patients that are diagnosed and treated in primary care, further, most often get, oh, sorry, yes, get prescribed medication. And then we see the last step, which is also quite sad. Most of those people keep living with their insomnia. They may have some relief from time to time, but most often the insomnia problem is coming back. So we see that there's this big gap between what the patient should actually receive and what they, according to treatment guideline, and what they receive in reality. So the big question is, can technology help close this treatment gap? So yeah, my thesis today is yes. So I think with thoughtful design, digital CBTI can scale access, it can standardize quality, it can also maintain clinical effectiveness, provided that we integrate it in well into health systems. And so therefore, let's connect that back to the guideline landscape. So checking the guideline once more. I've already mentioned that, but we actually see that CBTI is recommended in face-to-face or digital format. And the reason for this recommendation is that evidence for CBTI across formats is very strong. So when we quickly go deeper into the evidence, then we see that there's really robust evidence for CBTI. So with multiple trials and meta-analysis showing meaningful improvements across various treatment formats. So when we check the evidence here in this table, you can see on the very top the evidence for in-person, so one-on-one delivery of CBTI, and we see that these are really strong effect sizes. So everything that is larger than 0.8 is a large treatment effect size when we compare to control condition, and we see for face-to-face therapy, we see an effect size of 1.28. So this is the first part. We see that those effects are slightly lower for group delivery, but still very strong. So just below 0.88 with 0.79. And then if we go one step lower, then we see internet delivery on the bottom. And also here we see a very strong effect size with 1.04. So it's a bit smaller than what we see in one-on-one delivery, but it's still super strong in terms of showing really great potential that this could be a good option. So now, when we dive even deeper into the European guideline that I've showed you earlier, I've showed you the treatment path, but of course this guideline is full of information, and this table is one of it. So if we go a bit deeper, then we also already find recommendations for scientific-based digital applications across Europe. But as you can also see here in this table, there's a very nice column that shows reimbursed by national healthcare. And we can see that the reimbursement for these digital therapies so far is very limited. So to date, only Germany, the Netherlands, Sweden, and Scotland, and some regions in the UK, in England, offer reimbursement by the national healthcare. And one of these products, if you go through the names of these products, here in the table is Somnio. So this is the product developed by Mementor, the company that I work for, and therefore also the product I know best, and the product I will introduce you to as an example for how psychotherapy can be translated by technology. And also, I also wanted to use this as an example to also talk about the pathway, the digital pathway that was created by the German healthcare system. But before we dive deeper into this, I thought maybe to understand better why CBTI may work in various formats, a quick refresher or introduction on what CBTI actually contains may help. So if we go quickly back to what is actually cognitive behavioral therapy for insomnia, we can see this in the table, the different contents of it. So I've divided it into showing ones on the left side, the CBTI modules, and then the content that is provided by offering that module. So first of all, we have psychoeducation. So this typically is a module that talks about the basics of sleep, and about sleep regulation. So it's just very informative about how does sleep normally work. Then we have sleep hygiene, which is also something that I've already mentioned. So sleep hygiene is something that most patients will often have, can't come across until they reach a healthcare professional. So it's basic information about lifestyle and bedroom recommendations that one can implement in order to sleep better. This is, both of these, so psychoeducation and sleep hygiene, are modules that are very educative, so they themselves don't help a lot, but they already give the basis to be able to introduce the further or the upcoming modules. So the next one then is very important. We have stimulus control and sleep restriction therapy, which are the key behavioral modules. So here the patient learns to rebuild a good association between bed and sleep, and they also learn to match the sleep opportunity to sleep ability. So that sounds very superficial. So to go a bit deeper, these two modules, they give instructions to, for example, only spend as much time in bed as you can actually sleep. So if we see a patient who reports that he or she is spending 8 hours of 8 hours of time in bed, but actually only sleeps 6 hours of these 8 hours, and then sleep restriction therapy would recommend to only spend 6 hours of time in bed. So from that point onwards, that patient would only spend 6 hours of time in bed. And if the patient manages to sleep through, then there's an option to increase the sleep window. So then there would be, for example, an option to have 6 hours and 15 minutes. And taking the stepwise approach, the idea is to find a new sleep window that actually matches the sleep ability so that the patient is not spending any time awake in bed. And that very much is also what stimulus control suggests. So also stimulus control suggests to only go to bed when you're really sleepy and not do anything other, not do anything else in bed other than sleeping. Then also we have relaxation therapy. So these are any kind of techniques that facilitate relaxation and reduce arousal. So this could be something like imaginary rehearsal therapy, but it could also be meditation. It can vary quite a bit. It's just important that it makes you relax and makes the body relax. And lastly, we have cognitive therapy. So here the patient learns actively to restructure maladaptive beliefs about sleep. So these are things like thinking that you always need 8 hours of sleep. Cognitive therapy would question that belief and, for example, ask you, well, do you actually always need 8 hours of sleep? What if you only get 7 hours of sleep? Can you still manage through the day? If yes, then maybe that's not really true. So this is just a basic example, but it kind of brings up all the misbeliefs we have about sleep. And lastly, I also included sleep diary. It's not an educative component of CBTI, but it's also, I think, a very important part of CBTI. So throughout the whole therapy, patients are always asked to fill out a sleep diary every day. So we normally do it with the patients in the beginning to see how their sleep behavior is at the moment. So for example, also to be able to implement sleep restriction therapy, we need to know how the sleep is looking like at the moment. And it's also something that patients will be encouraged to do throughout the therapy. And I think it's also, it's probably, it's also a component of CBTI because the patient is trained in getting a feeling for their own sleep every day. And I think based on these components, maybe you can already see that they can actually translate quite well into digital therapeutics. So I will quickly show you this in the next example. So I've mentioned already that, I will use Somnio as an example for digital CBTI, since this is the product I know best. But I also had the chance to test a few of the other digital applications, and they are all pretty similar. So most of them, they deliver CBTI content in a modular basis. Sleep tracking in form of a diary is always essential. Some applications offer tracker connection. So for example, with an actigraphy device like Fitbit, Garmin, or maybe an Apple Watch. Some have an avatar who guides through these treatments. Other use chatbots or video recordings of healthcare professionals. So all of this is possible, but it's always essential just to get through the content and be able to implement it on your own. And how this information is delivered can vary. For Somnio, we have an avatar. He's called Albert. He's basically an animated sleep expert. He also asks questions and then offers basically also the option to have a bit of an individual path. So depending on the answers, you get delivered different content. So maybe some things are more interesting to you than others. So with this avatar, we have the option to guide the patient a bit more on an individual basis, but also this might be possible to do with a chatbot, for example. And what I've already mentioned, I think the sleep diary is very, very important. And here, this is one example of how or why digital format is actually quite good, because when we do it in face-to-face, then most often the patients have it on a paper pencil basis, and with such a paper pencil format, you're not actually able to provide any kind of overview in form of a graph or anything like that. So you just have the day-to-day data, and you're not able to show an overview like you have, for example, in an app. So that's one thing that is actually quite nice, nicely done with digital therapies. So in Somnio, the CBTI pathway is delivered through these modules, such as introduction, sleep diary, sleep knowledge, and practical exercise. So these are the first modules that I've mentioned earlier. So like the psychoeducation about sleep. Then we have insomnia cycle, which is a cognitive module of CBTI. Sleep times, which is the sleep restriction therapy, relaxation, sleep behavior thoughts, and everyday decisions where patients are asked to implement what they've learned already into real life, and followed up by closing session and follow up. Yes, I've already mentioned that the program uses an animated sleep expert called Albert. And in Germany now, people, for example, can use this app for 90 days. So it's quite a long time to go through the program and try to implement it. But now the question is, or what I actually wanted to focus on, is how do patients actually access such a digital CBTI intervention in Germany? Because I also wanted to dive into the healthcare situation. So the German example for reimbursed DTX is quite special, because until now it's pretty much the only system. There's also a very comparable system in France, but in France there is to date still not one single application that has been accepted by the French healthcare system. So there is a process, but no technology has managed to get access to that. So in Germany, there was a new law in 2019 that allowed digital health applications, so-called DiGAs, that were then integrated into the German healthcare system. And since October 2020, the first DiGA for insomnia became available via prescription. And now since 2024, we actually have 2 more. So in Germany, you can now select between 3 different applications. And the access is via license codes covered by healthcare insurances. And then you get the license for 90 days with repeat prescription possible. So we not just have that for insomnia. We also have that for example, depression or pain, and like chronic pain, like back pain, or for adipositas. So there's a lot of diseases where there's now digital health applications available in Germany. And how it works is that you would go to your GP, you would tell them about your problem, then the GP would give you a prescription for that digital healthcare application. And with that, you get really like a like a receipt. You would then bring that to your health insurance, and then the health insurance would give you a license code, and then with that license code, you then type that into your app, and then you can access it. So it's, I don't know, maybe this got through already, but it's not the most easiest process. It's quite, so the patient has to have quite a lot of patience to until they can actually start the app. And how does an app or a product actually become a DiGA? So not every app can just be an app that is reimbursed by the healthcare system. It's quite a long process. So once the product is developed, it needs to go through a clinical trial, and that can either be a pilot study or a full RCT. In most cases, the pilot is already an RCT, and the other RCT is just an even bigger RCT. It needs to be a medical device, which also has quite a lot of requirements. And then it's possible to either go for permanent listing or for preliminary listing. In both cases, there's then a free choice of price for the first year. And then afterwards, there's a price negotiation with the healthcare insurances, and then you have the permanent price that is then given for that application. And I think up to date, we have about 40 DiGAs that are available in Germany. Yeah, but let's go back to the German healthcare situation before the DiGA came, because one question that I wanted to answer is also, or the question that we wanted to answer is, can technology actually fix this problem of the insomnia journey? So we have some data from German healthcare, for German healthcare services that is actually, I think, quite interesting. So when we look into the care situation for insomnia before the DiGA came, we have data from the year 2017 to 2018, so it's quite old, but unfortunately we don't have anything that is newer than that. So if we look into all workers in Germany and we check how many of those actually meet criteria for insomnia, then we see it's quite high with 26%. And if we then go a bit deeper, then we see out of all of these, only 45% actually consulted their GP about a sleep problem. So this is quite similar to what I've showed you in the insomnia journey. So that only very few people who have those insomnia problems actually even go this first step and consult their GP about it. And then once they've consulted their GP about the sleep problems, we see that out of those, only 1.6% were given a diagnosis according to ICD-10. So only those were given a diagnosis for insomnia, which can have different reasons. But because of the way the data is made, this 1.6% are the only people that we can look for when we want to check what treatment did they actually receive. So when we check these 1.6% of people who got the diagnosis, so we see those here, we see that most of them were given medication. So again, this kind of meets what we saw earlier in the survey data. Most people get sleep medication, and 9% of those who had the diagnosis for insomnia received some form of CBT. So that's a bit of a problem with the coding system. So we don't see if they got CBTI, we just saw that they got some form of CBT, which could also be, for example, cognitive behavioral therapy for depression or anxiety. So we don't know for sure if this was CBTI. But even if it would be CBTI, it would still be a very low proportion of all of those who had reported sleep problems in the first place. And now we get more data, because now we also have data from the from the DiGA path, because this is data that is reported on an annual basis. So when we take the data from 2024, we see that in this year it was about 54,000 codes for an insomnia DiGA. So I mentioned that in 2024, we actually had 3 different DiGAs for insomnia. So we saw that these are the codes. So this is almost as much as people who have received some form of CBT. So when we go back and put this all together, then it's actually, I think it's promising, but it's also still quite sad. So if we put it all together, then the early indicators suggest that the introduction of the DiGAs for insomnia may have increased the access roughly from about 0.12% to 0.25%. So still very modest, still a lot of people don't receive the treatment they actually should. But at the same time, the DiGAs have doubled the share of patients receiving evidence-based care at scale. So maybe one big question or something that you may ask yourself as well is why isn't the access even higher? So we can quickly look into barriers that are reported by clinicians and patients. So also for this, we have some survey data from health insurances. So when we ask GPs why why isn't insomnia digital treatment even more present in our day-to-day healthcare situation, then we see that actually only 31% had really actively informed themselves about the DiGAs. I mean, it's something that came 2019. Before that, it didn't exist. So just 22% actually felt confident distinguishing high versus low quality apps. So then they weren't really able to differentiate that a DiGA is different to a typical wellness healthcare app. Even though there's a really tough process that the manufacturers have to go through in order to prove that it's a good app that can really do something. So also only 22% felt confident explaining the app to the patient, which I think is a very big issue, because if you were a patient and you go and get a treatment and the GP isn't really able to explain it to you, I think it doesn't really give you much confidence in using it. Also, data privacy concerns were very common, even though the criteria for data privacy for DiGAs is super, super high. But yeah, complexity also concerns were affected in 35%, and only 3% believe that DiGAs are meaningful, or DiGAs meaningfully activate patients in self-management, which I think is also quite sad. From the patients, we also know that 20% struggle to translate the recommendations into daily life. So these are people that have used the DiGA. 50% felt that recommendations didn't really fit their personal situation, and 37% reported that they haven't received any information by their GP before. So what I just said earlier, that if the GP isn't very confident, then it's very unlikely that the patient will be. And yes, 37 and they also, I think one issue that I mentioned earlier is that I said that the patient needs to be quite patient with the app. So this is also something that we can see from the data, that it takes up to 30 days to provide access to the DiGA. So yeah, even though access should be very much scalable and it should be available immediately, it's still a long time that patients sometimes need to wait until they can actually activate their app. So yeah, so this is kind of a not so happy news, or also something that explains a bit why the DiGA isn't scaled more than it could be. So this data is not just for CBTI, it's for DiGAs in general. But I think despite these barriers, the crucial question is, does digital CBTI or digital sleep therapy work in real life? So kind of going back to the positive life, or the positive side of the digital therapies. So when these barriers that I've just introduced are overcome, the question is, can digital sleep therapy work in real life? And so I mentioned already that in order to become a DiGA, the manufacturers have to provide quite a lot of evidence that the DiGA really works. And so I can just quickly go back to the example of Somnio. So until now, there's quite a lot of evidence that we have provided to convince the healthcare professionals, but we've done quite a lot of RCTs to basically have a first evaluation. Does the app actually work? Then we tested it again in a larger sample, more heterogeneous, more closely to real world, and we have very long-term 12 months follow-up data. We've evaluated against a sham app, so a placebo kind of controlled application, to show that it's not just about tracking sleep, it's actually a lot more than that. And then we've also gone into the typical comorbid population. So we've tested it in people with insomnia and depression, and we've also tested it in insomnia and chronic pain. And the message was always the same, no matter how we tested digital CBTI, we're very convinced by that. And this is not just evidence from Somnio, it's also the evidence we have from other digital CBTI apps. It's very convincing. It's something that is that patients can really use on a self-help basis. and that can be very powerful. But one thing I wanted to mention is that what is very nice about digital therapeutics, it's that we can actually have the chance to test their effectiveness in real world. Um, and I've quickly highlighted the study and wanted to introduce you to that one as well, because this is something that we wouldn't even be able to do with face-to-face therapy because we wouldn't have any data on it. But digital therapies give us, if they're implemented into real world, we actually have a real chance to get an understanding of the disease, how it looks like in real world, but also how it can change with therapy. So I wanted to introduce you one publication that we've done on Somnu. And yes, as I mentioned, I think the advantage of the DiGA model for research is that with that reimbursed digital therapy, it creates the condition to gather real world evidence at scale without disrupting routine care in primary practice. So yeah, this is now here evidence from a 5,000 user primary care cohort. And what we've done here is that we've randomly selected a sample of 5,000 users who got prescribed Somnu by the healthcare professional and who completed the 90-day program between 2021 and 2022. So we excluded everyone who had an insomnia severity score lower than 8. So that would basically indicate that there's no severe insomnia. And the endpoints we included were measures that we would take within the app, so like the insomnia severity index, and but also sleep diary metrics that we've clustered according to the modules that needs to be done within a certain time frame, and all the analysis, of course, because it wasn't powered for any statistics, so it was only descriptive. But we can quickly just have a look what it tells us about the insomnia in primary care. So one thing that I thought was really interesting was even just looking at the baseline characteristics. So what we saw in this 5,000 user cohort was that 71% were female. So yeah, very highly prevalent amongst women. 39% were aged 50 to 59. So this was the largest age group. So yeah, and the average insomnia severity at the beginning was 18 or above 18, which is indicates quite moderate to severe insomnia. We see that the average wake time after sleep onset at the beginning was 122 minutes, which is it's super high. So it's more than 2 hours of just lying in bed awake. And this is one thing that I was very intrigued by when I saw this, because it's a lot higher than what we see in our typical RCT trials. Also, the average total sleep time at the beginning was 323 minutes, so it's on average just about 6 hours, which was also quite a lot lower than what we see in RCT trial data. And the average time in bed at the beginning was 530 minutes. So you can also directly see that there's a super big mismatch between the total sleep time and the time that those patients spent in bed. So yeah, about a 2-hour mismatch. And also average sleep efficiency at the beginning was 63%. So also, again, like just a lot lower than what we would see in clinical trials data. And yeah, with Somnu, we have the option that people can either self-report their sleep diary data, or they can also combine a tracker. I think we often think that people always want to use trackers and they don't want to fill it out themselves. But what we saw in this real world data is that actually only 10% use the tracker, and most of the patients choose to self-report their data, or they didn't have a tracker. That's also an option. And what we saw in these results, again, it's just descriptively, it's just that the insomnia severity index was reduced by quite a lot between the beginning and the end, and it was actually quite the size that we typically see in RCT data as well. And what I just thought was also interesting, that we could look into the different groups. So we could look between women and men, we could look into different age categories, we could look into different severity of insomnia. And pretty much we can see that there's no indicator that anything would prevent people from improving. So at least in this data, I mean, it's quite superficial, but there was no difference for any of the groups. I think the only thing was that the improvement was a bit lower if the EASY score was low at the beginning, but that's very much a ceiling effect. If those people didn't have severe insomnia, there wasn't much to improve. So then I mentioned that we can also look into sleep diary data. Also here we can see quite nicely how time in bed improved, or not improved, but like it got changed by quite a lot. And now you can see on the bottom, you can see the x-axis showing different clusters. And yeah, it's a bit not so easy to understand, but the important thing is that in cluster 3, this is when sleep restriction therapy is introduced. So this is when the behavioral modules kick in and they give the recommendations to spend less time in bed and to put this into practice. And this is, for example, something we can see quite nicely how those people really implemented what was suggested. So just supporting the theory that that digital tools can be quite good in initiating behavioral change, maybe better than a self-help book, but this again would be something that needs to be compared. Yeah. And yeah, when we then go back into or go deeper into the sleep continuity data, then we can see how these behavioral changes reflect in sleep improvements. So once the time in bed was reduced, we could also see that sleep onset latency improved, that wake after sleep onset improved, and that sleep efficiency got higher. And for sleep improvement, we only see very, very little change. But this is also something that we would see for face-to-face trials. So CBT isn't typically changing sleep duration much. It's more working on the sleep continuity variables. And one thing that I should mention as well, we had to analyze them differently. So self-reported diary data and tracker-derived data is analyzed separately. And very important to note that these are different people. So not the same people measured in the same way. So it's different people because you could only either have the tracker or self-report, but it's not possible to do both. So pulling this all together, what should we conclude? And what are the open challenges? So here are the key points. I think first, digital sleep therapy works. Multiple studies worldwide show how digital CBTI is effective and has very strong potential to fill the treatment gap, especially I think when it's thoughtfully integrated into care pathways. Maybe the German example isn't yet the best. Maybe the future will tell if it will change. So I think the distribution of those digital therapies depends very heavily on health systems, designs, and also policies. In Germany, even after almost 5 years of DiGA, the access remains limited due to really complex patient pathway, low GP awareness or willingness to prescribe, but also insurer processes and economic pressures on manufacturers. And third, when patients do access care or real-world results are comparable to clinical trials, for example, the cohort shows that the reduction in the EASI is very much the same as what we see in RCT findings. Digital health also, I think, yields very new insights into sleep behavior at scale. So like the long baseline time in bed, which was like almost 8.5 hours, compared with the population estimates that would say that it's something between 7.5 hours, around 7.5 hours. These are the key messages. And I think with that, I want to thank you for your attention and